I hope now it's better.
Yeah, it's good now.
Good day, everybody. Good day. And thank you very much for the invitation to speak about cutaneous T-cell lymphoma. Yeah, so I will speak in the next minutes, about 20 minutes, but definitely not more. I know we are a bit running behind the time. And my topic is cutaneous T-cell lymphoma, exploring all compartments from diagnosis to prognosis. Okay, you see, these are my disclosures. So cutaneous lymphoma are a heterogeneous group. We have B-cell lymphomas, we have T-cell lymphomas, and really originating from other type of cells like NK cells, and all of them have a different clinical presentation, a different histology, and most important, different prognosis. So the definition of cutaneous lymphoma entity itself is the best biomarker. So you have, before you start with staging and treatment, to know which type of cutaneous lymphoma it is. And as an example, if you have a mycosis fungoides, as you see on the right side with a tumor stage, is a situation where the patient has a bad prognosis, and you need here also intensive treatment. On the other side, if you see just below nodules, and you have a cutaneous anaplastic large cell lymphoma, and then you have a situation where the prognosis is much better. So just briefly, I want to show you in this table, if you have mycosis fungoides, especially in the early stage, the prognosis is very good, 5-year disease-free survival, disease-specific survival is 88%. And as an example, if you have anaplastic large cell lymphoma, as I have shown you before, patient with huge nodules, but however, it's a very benign clinical behavior. And you see the 5-year disease-specific survival is about 95%. On the other side, we have cutaneous lymphomas which have very aggressive behavior, like Sézary syndrome or extranodal disease. So definition of the cutaneous T-cell lymphoma entity itself is most important and is the best biomarker. Then the next step is to define the correct staging. I managed earlier today the situation in the early stage of mycosis fungoides, which includes stage 1A till 2A. So you have in these cases patch and plaques, less than 10% in 1A, more than 10% in 1B. And on the other hand, some of these patients, it's about 15 to 20%, will experience during the clinical course of the disease a progression. Fortunately, it's only a small part, it's about 15 to 20%, but we have this part where they develop tumors or erythroderma, or maybe also blood involvement in case of a Sézary syndrome. And depending on this clinical stage, also is of course associated the prognosis. In the early stage, as you see here, the first curve in blue, 1A, patients have a very good prognosis, so have only patch and plaques. They usually live as normal people who don't have a cancer. On the other side, if you look like here in brown, if you have a tumor stage or have an organ involvement, the prognosis and overall survival is much reduced. Therefore, the exact staging is also very important to define the stage and also to define which is the right treatment for the patient. Is it enough to have just a skin-directed therapy in case you have only skin involvement, or do I need a systemic treatment because maybe the patient has also a blood involvement or lymph node involvement? And on the other hand, we know that some therapies are responding much better, are working much better if you have blood involvement compared to these without blood involvement, like the antibody mogamulizumab against the chemokine receptor 4. So the first and most important step, and also the most difficult step, especially in the early stage, is in this staging the definition of the skin assessment. Here you see a patient with patches, which is about stage 1A, 1B. And why it's a difficult stage? Because the differential diagnosis is very common, and like chronic dermatitis, psoriasis, contact dermatitis, eczema, or tinea corporis. And because of this differential diagnosis and this, let me say, not really specific clinical symptom of cutaneous lymphoma, it took usually about 3 years to define the first diagnosis in mycosis fungoides. So what to do to find the right diagnosis? Of course, which is here not mentioned, we have to think about this differential diagnosis always, especially if you have also atrophy of the skin and you have itching and it's a chronic disease, and especially if it's in localized in region with it's not sun exposed. So of course, you see here the questions, and I will go on. So of course, thinking about cutaneous lymphoma as a differential diagnosis is most important, and then the next step is to take biopsy. And in the biopsy, you look for the H&E histology or for the GIMSA, and in addition also for the immunohistochemistry. And although we have no marker which is specific for malignant T cells, we have first in the normal histology the pattern that we have epidermotropic infiltrates. The lymphocytes are going into the epidermis. Sometimes you have this pouchier microabscess. And you see also the thickening of the collagen bundles in the upper dermis. And on the other side, which is helping, is that this population showing the marker of, in most cases, CD4 expression, CD3 expression with a T cell marker. And sometimes it's also important to look for other markers like CD30, which could be important for treatment. So based on the histology compared with the clinical picture, we would suggest early stage of mycosis fungoides. You can also define the stage by the histology, since you have a very superficial epidermotropic infiltrate. It's a sign of a patch and plaque. And when you have a deep infiltrate, a nodular infiltrate with only limited involvement of the epidermis, then it's more looking like tumor stage for advanced stage mycosis fungoides. You can in addition use also T cell receptor gene rearrangement. So that means you take from the same biopsy you already has made, you took the extract the DNA, and doing a PCR, which is meanwhile routinely done. And in the PCR, you look for the rearrangement of the different genes of the T cell receptor. And at the end, you got a sequence which is highly specific for each single T cell. And of course, also for the T cell malignancy, which is originating from this T cell, where they have all the same rearrangement, which you can see and then in a gene or in gene scan analysis that all cells have the same T cell receptor rearrangement. So as a definition, that is monoclonal. And if you have different types of T cells, like an inflammatory disease, like eczema or psoriasis, usually we have several populations of T cells with different T cell receptor. Then we have different types of peaks. So if it's suspected and it's not clear by clinical picture and histology alone, molecular bioanalysis for T cell receptor gene rearrangement is very good help. And of course, you always need to take all together. Fortunately, or maybe for some people, unfortunately, there is not a single technical analysis which proves that this is a mycosis fungoides or cutaneous T cell lymphoma. You need always to correlate it to the clinical picture. So the clinical pathological and molecular correlation, if you take it all together, ideally, if this is all in one hand, then I have a good chance also to do a clear diagnosis in the early stage and have not to lose three years for this patient. So if you have the diagnosis, then you look for the T staging, you look for the skin compartment, if it's more or less than 10%, or if you have a tumor, or if you have an erythroderma, because this extension of skin infiltration alone is also already associated with prognosis. As I mentioned, if you have limited infiltration of the skin, less than 10%, like 1A, survival like each other people without cancer, and if you have like in T3 in yellow tumor stage or T4 erythroderma, this itself defines a worse prognosis. So having defined the exact entity and the skin stage, the next step is to define the situation in the other compartments, especially lymph node. As you see in this clinical picture, the peripheral lymph node which is near to the skin, are usually the first extracutaneous manifestation of cutaneous lymphoma. And of course, also the involvement of the peripheral blood. So, what about the lymph node? If it's clinically suspected, as in this patient, which is already clinically overwrought, or by ultrasound, then you have to prove the lymph node involvement by taking a biopsy. Of course, also in the lymph node, maybe it's more difficult to define a cutaneous lymphoma infiltration than the diagnosis of the skin in itself, because lymph node is full of lymphocytes. I think the cutaneous lymphoma T cells are small as any other normal T cells. And in addition, you sometimes find a hint that it could be something dealing with skin. As you see here, there is you find here some black pigment, and this is melanin. And melanin is coming, of course, from the skin. If you have an itching disease like in cutaneous lymphoma, then you have this pigment incontinence. That means this melanin drops to the upper dermis, then is taken by the macrophages, which then wander to the lymph node. And then you find it also in the lymph node. And that's the reason why it's called by the pathologist dermatopathic lymphadenopathy. And this is a sign that could be something dealing with the skin. However, it's not specific for cutaneous lymphoma. Every extensive skin disease with erythroderma due to, let me say, psoriasis, atopic dermatitis, pityriasis rubra-pilaris, which is also itching, leads to pigment incontinence, and then it's taken by the macrophages to the lymph node. So it's only a sign that there is something in the skin, but it could be benign, it could be also a lymphoma, both. Since it's difficult by histology and immunohistology alone, we could show several years ago that if you combine this analysis with the T-cell receptor gene rearrangement, and you look in the lymph node for this T-cell receptor gene rearrangement, and you compare it to the clonal rearrangement in the skin, you can detect it much earlier than in the histology, and we could show also that it has an impact regarding overall survival. So, defining the clone in the skin and find the same clone in the lymph node, it's a proof that you have a lymph node infiltration. And since it has an impact on the survival of the patient, it is also included in the classification system of the International Society of Cutaneous Lymphoma, or the INT'L. And you see in the middle node for lymph node, and you have the histology, but you have also clone negative and clone positive. So the situation of the T-cell receptor gene rearrangements of the lymph node is also included in the classification of the staging for cutaneous T-cell lymphoma. How it's, so skin erythema, if you have the case of erythroderma, it's always a very difficult differential diagnosis. You have pityriasis rubra-pilaris, psoriasis, atopic dermatitis, a drug reaction, severe seborrheic dermatitis, especially in immune-suppressed patients, or it could be cutaneous lymphoma. Of course, you need here also the histology, where you see some epidermotopic infiltrate. So in this case, it's confirmed, but you have now the diagnosis of a cutaneous T-cell lymphoma. And the next step is to differentiate it, if it's only, let me say, erythrodermic mycosis fungoides, or if it's a Sézary syndrome. And for the definition of Sézary syndrome, of course, we need the next step, the situation in the compartment blood. And for the blood, so we have defined by histology that's a cutaneous T-cell lymphoma. So what is the next step? What we need for the blood? Due to the time, I will go on. Most important is the flow cytometry to access the blood tumor burden. And for this, we are looking for several markers. We're looking in the blood smear for atypical cells, if we have more than 1,000 or not. Or we're looking also for the T-cell clonality. And, which is also very important, we are looking for in the FACS analysis. So we're looking at the ratio for CD4 to CD8 cells, assuming that the malignant cells are CD4 positive. If they are increased, we have an increased ratio to CD8. And if it's more than 10, then it's diagnosing Sézary syndrome. And as a help, also further markers like CD7 loss or CD26 loss. So we need peripheral blood, T-cell clonality, and also, which is very important, the flow cytometry. It's very helpful for the diagnosis, and let me say, in case of a Sézary syndrome, also very helpful for follow-up if the patient is responding to the treatment or not. So, let me say, in this patient, where it's clinically suspected of a Sézary syndrome, due to the erythroderma and also to the palmar plantar hyperkeratosis, we had T-cell receptor clone positive in this case. We had a high tumor burden, more than 1,000 per microliter, and we found that the CD4-CD8 ratio is bigger than 10. We have a CD7 loss of more than 40%, CD26 loss more than 30%, and this together is diagnosing a Sézary syndrome. So, here you see, if you take all the compartments together, in stage 3, we have in stage 3, we have a lymph node involvement. In stage 4, like we said, B, we have a blood involvement. And you see in the advanced stage, if you have 4B, we have a very bad prognosis. And so blood involvement, if it's B2 especially, it's a sign for very aggressive disease. And you have to take this into account when you treat the patient. So it's not enough if you just give skin-directed therapy like PUVA. You need an additional systemic treatment where you target the blood tumor population. And of course, you can use this genetic analysis for T-cell receptor gene analysis, not only for the first diagnosis in the skin or in the lymph node. You can use the same technique in the blood, and you can correlate it. And by this, you can see if it's the same malignant T-cell population or not. And again, most importantly, it is very important that you relate these clones which you find in the compartments lymph node or blood. You have to correlate it always to the T-cell receptor clone of the cutaneous skin lesion. If you look just in the blood, also it's clonal, it means nothing. Why it means nothing? Because due to age alone, we are getting a limited repertoire of T-cell receptor gene rearrangement. So if you're getting older, it's the chance that you have single clones is very high. And this means nothing regarding a malignancy or regarding cutaneous lymphoma. But if it's identical T-cell receptor rearrangement by the size or by sequencing, as that what you find in the skin lesion, then it's a proof that it's really a blood involvement of this cutaneous lymphoma. And therefore, you need always this correlation. And of course, and here can nobody help you, you need always a correlation to the clinical picture. And if you take this together, only then you can have a clear diagnosis of a cutaneous lymphoma and as a malignancy, and based on this, start the treatment. So that's the summary. In early stage, you have usually only skin involvement. In advanced stage, like in stage 3, you can have lymph node involvement. And in the stage 1A, 1, 2, you have also blood involvement. You have to take all this together. And when you treat the patient, always consider if you have just skin infiltration, skin-directed therapy like phototherapy, like clomiphene gel, like total skin electron beam is very helpful. And if you have lymph node involvement, maybe you can combine it with radiation. But in case you have blood involvement, you have always to compare it with a systemic treatment like retinoids, interferons, or like the new antibody against chemokine receptor 4 like mogamulizumab. So staging and looking to the different compartments, this is the aim of my talk, is very important to provide for the patient an effective treatment, which also aims against all involved compartments. And when you have done this, you can start with the approach treatment for the patients. As I mentioned earlier today, here you see the treatments for the early stage, especially phototherapy, monotherapy, or in combination with systemic treatment like interferon or retinoid. And when you have an advanced stage, to combine it always with systemic treatment. Or we have the possibility in the last years with two new effective antibodies like mogamulizumab, which is a monoclonal antibody against chemokine receptor 4, or like brentuximab, which is a fusion protein against the molecule CD30. And by this, I want to thank you very much for your attention, open for questions. I thank you also for the excellent organization of this meeting. And I want also thank Kiowa Queen for their efforts and for their support to increase the awareness of cutaneous T-cell lymphoma. Thank you very much.